Dr. Munoz is going to present the case. Yes, from room number 3 with Dr. Fermin. Let me present the following case. This is a 74-year-old male patient with a diagnosis of In the last 2 years, the patient has been decompensated without response to optimal medical management. The patient presented dyspnea. We are having sound problems. We can't hear the microphone in the room. Well, let me start again. 74-year-old male patient with dilated non-ischemic cardiomyopathy with deterioration of the functional class despite optimal treatment, dyspnea, presyncope, and orthoapnea. Part of the clinical history of the patient includes ischemic cardiomyopathy, ejection fraction of 30%, complete left branch block hypothyroidism. The patient was a smoker for 40 years, 1 pack a day. So the patient has COPD. The patient has been treated with levothyroxine, furosemide, carvedilol, spironolactone, losartan, and aspirin at the doses you can see on the screen. The doses have not been increased because of intolerance to the medication and hypotension. This is the ECG of the patient in sinus rhythm. Here you can see an alteration of synchrony because of the left branch block with 160 milliseconds in QRS. The Holter, we were not able to document ventricular arrhythmia, very sporadic supraventricular. We did not observe any significant pauses. And something to document the deterioration of the functional class. This is the echo, which was done recently. Here we see generalized hypokinesis on a septum, which moves asynchronically because of the left branch block, and the dilated ventricle. 20% ejection fraction according to the echo. We ordered myocardial perfusion, which shows that there is no ischemia. There is a bit of necrosis in the inferior wall and significant dilatation of the left ventricle with a drop in the systolic function. An MRI was done. And we documented fixed perfusion defects, enhancement defects, and with this diagnosis, we concluded that the patient has a non-ischemic dilated cardiomyopathy, right branch block QRS 260, COPD, and hypothyroidism. So this is the case we will treat in our room. Dr. Fermin? Well, this is the patient as was already described. We have not begun yet. In 25 minutes, we can be back with you. We are not ready yet. Well, good afternoon. We are here in Lab 4. We are pretty advanced in the cardio resynchronization device placement. This is a St. Jude device. And Carlos, the fellow, has been having some problems with the case presentation. I'm sorry, there is a lot of background noise and I can't hear the speaker. Well, Carlos will be presenting the case. Well, good afternoon. The patient we have here is a male patient, 71 years old, with a history of ischemic heart disease, ejection fraction of 15%. The patient was surgically revascularized in 2011 with a mammary CABG. And presently, the functional class is 3/4, despite optimal medical therapy for cardiac failure, or at least the maximum tolerated by the patient. The surface electrocardiogram shows sinus rhythm, but a disorder of the intraventricular conduction. The QRS is 180 milliseconds. Doesn't meet the criteria for complete left branch block. The ECG has an ejection fraction of 15% with no significant valve disease, and the patient was recently stratified with myocardial perfusion, which with the report of necrosis and a necrosis extension of approximately 45% of the mass of the left ventricle. So in summary, this is a patient, 71-year-old, ejection fraction 15% despite optimal medical management and a disorder of intraventricular conduction with a very low QRS. And now Dr. Rodriguez will show you how much progress we have made. Well, very quickly, because I know that it's quite late. Well, this is the fluoroscopy. Very quickly, let me tell you that we did 3 punctures, 3 subclavian punctures guided with vascular echography or vascular ultrasound. It was quite easy to do that puncture. We then placed the ventricular lead, initially the ventricular electrode, Durata 7122Q, and we obtained an R wave of 6.3, a threshold of pacing less than 1, with a satisfactory impedance. Then we placed the atrial electrode, which is a 2882 electrode with adequate parameters with absence of phrenic nerve stimulation. Then we placed the sheath of the coronary sinus. This is a new design of St. Jude Medical. It's CPS Direct. This is not a peel-away sheath as they used to have. This sheath has stainless steel, a pressed stainless steel coating, which allows for additional torque for maneuverability inside the cavities. We use the usual approach, passing the sheath and the guide wire to the right ventricle. And we moved clockwise posteriorly until we were close to the coronary sinus. It didn't went into the coronary sinus initially because we manipulated the guide wire that we had inside the sheath, and we observed that the mitral annulus is being surrounded. We advanced the sheath. There has been some difficulty at that side, probably. This was simply a game of coming in and out and going in and out until finally we were able to pass and overcome the valve. And now we are in the coronary sinus. Then we did an injection, not an occlusive injection. Usually I try to administer occlusive injection, but really this first injection showed us a very favorable anatomy. This is an oblique right. I'm sorry, we are losing the sound. I think that well, here I have very good images, very good fluoroscopy. I think that the pre-recorded images, I can't darken those images or to make them better, unfortunately. Well, this is the left oblique image, 35 degrees. There is a posterolateral branch, which is very good for the case. I insist once again, this is a non-occlusive injection. Then we used a subselector of 135 degrees. It's CPS I'm universal. And we had some difficulties with it because in the right oblique, I was unable to enter the branch, and finally we were able to enter the branch in the left oblique. Once again, we did a selective venogram of the branch in the left oblique and the right oblique. In this case, I would ask you, which would be the ideal vessel? I don't know what's your opinion, Vidal, about this venogram. And I think it's easier to look at it from the left oblique. I would say that the furcation, you can place it laterally over here in the ascending aspect. Well, that was our impression. Probably that was the best branch for us. So we advanced a guide wire. We placed the guide wire on the electrode, as you can see here, on the sheath of the coronary sinus. Here we have the electrode that goes through the subselector. No, we don't see anything to the right. So now I am working more on the right oblique. Maybe you can see a bit the guide wire that we tried to navigate up to this point. And at this time, that's the situation we have. I will use fluoroscopy. I will show it again. The guide wire apparently is in the right place. The subselector is a little bit outside. And let's now go on to move forward with the electrode. Which is the guide wire you are using? We are using a St. Jude Medical CPS courier. It's a long guide wire. It's not a mixed guide wire between a stylet and guide. It's a long guide wire, 197 centimeters. It's a conventional guide wire, very similar to a floppy. I feel that we have a, well, the sheath is coming out apparently. The subselector. I can't advance the electrode anymore with this sheath. I am trying to improve the position of the subselector. Carlos, could you help me to prevent the subselector from coming out? And I would say that with this better support, we can advance the electrode a bit more. Honestly, I would say that this is a very good site. I don't know what you think about it. Would you try at this point to do it, or would you like to advance more or to do something different? So let me hear your opinions, your views. Yes, I would like to know. The left oblique, please. How good is this image? Can you hear me? We can't hear you. We can't hear you. Would you like to take any measurements at this point, or would you try to advance more? I am tempted to measure, advance a bit more. I think that's feasible, but maybe it's going to go more apical, and I believe that the exit, which is 140 degrees, will give us a good stability of the electrode. So I would prefer to measure right now. If you want, we can measure. Usually I try to start measuring with the electrodes in the middle, just to get an idea of how the pacing would be more basal. So I'm going to connect 3 and 4. We can put the screen of the programmer shared with fluoroscopy so that you can see the measurements. Thank you. So Erika will tell us about the measurements at this site. Wave R in the left ventricle of 66377, impedance 672, 674. We are going to pace at 10 volts in BVI 90 with 0.5 of pulse. At 10 volts, we don't have phrenic stimulation. Or 7.5 capture, there is no stimulation. 5, 4, 3, 2, 1. 0.6. 0.5. The threshold is 0.6. It seems to me that there is a very good threshold at this point. I don't know whether you would like to. It's not so apical, it's more basal. We could try 3, 4 if you want. Would you like to look at 3, 4? No, no estamos oyendo nada. Well, if we have time, I think we can do it. Do you have another guitar here? So maybe we can measure the distance between the electrograms of the right ventricle and the site we are measuring in the left ventricle electrode. I don't have the other leads here, so please wait.
Ya me están abriendo otro juego de cables. Dame un segundo. Los conectamos. Toma, Erika. Sí, uno de los...
Okay, we can do this. We have connected the coil of the right ventricle. Now I'm going to place the left ventricle at 1 pace. Yes, you have to do normal pacing. 5 volts. Only the left ventricle. For the time being, only the left ventricle. There is no need to measure, just pace at 10 volts. We don't have phrenic nerve. Just go down, 5, 4, 3, 2, 1. So here we have a threshold below 1, and obviously there is no phrenic nerve. We are going to pace here with 2. In the coil, pace at 10 volts, and also the left ventricle. There is no phrenic stimulation, 5, 4. We don't have phrenic nerve stimulation at 2, at 3. No, we don't have phrenic nerve stimulation, 5, 4. No phrenic nerve. I think that in general we have good thresholds in all the stimulation vectors. We don't have here the phrenic nerve. We can measure the distance between electrograms now to see how distant. I am going to place 3, 4 of the left ventricle against, we can place it against the tip of the coil of the right ventricle. In this case, I'm going to place the tip So let's increase the speed, Erica. The other room is going to be ready in about 15 minutes if you want to stay. Well, Diego, that is the ideal situation of having the thresholds without a phrenic nerve around. Yes, really, this was a very... No, go back to the beginning. Go back to the beginning. We have 133 milliseconds between the bipole of the right ventricle and the basal mass of the left ventricle. Honestly, I believe that at this site we are pretty well. I would say that this is a good site to remove the introducers and to finish the case. I don't know whether there are any questions or any other suggestions. No, I fully agree with you. I think that, yes, we have a question here. Microphone, please. We didn't hear. The question I would like to ask is whether well, all the places where you have stimulated the width is more than twice the basal record. I think that the second distal electrode has a QRS width. He's talking about the QRS width. I don't know whether you understood the question. Well, my personal practice is that after the implant, when the patient goes to the post-op room, I do a series of EKGs with no stimulation. Only right stimulation, then left pacing, then biventricular, different electrodes and different times between the right and the left ventricle. And I see the ECGs in order to select the most appropriate QRS. But if you look at it, during the threshold, you are just pacing the left. You saw it in BBI. But you must consider how to fuse stimulation or pacing with intrinsic conduction. The time is very short. So you can privilege or place the negative hysteresis here and have a fusion. With the 4 options, you can choose the best. Well, I say this because sometimes you privilege the time when you indicate a resynchronizer, the QRS. The wider, the better the response. And many times after we implant the resynchronizer, we leave it with the same QRS width, sometimes wider. Yes, but you may have a QRS which is more fit, and the probability of response will be better, in my opinion. Well, we have more or less the same approach for the procedure, and in order not to change the alligators, what we do, well, I feel that we are in a very good vein. We don't have a better vein. The electrode is on the good side. We have good thresholds in general in every pole. And the more basal electrodes are at a very good location. So what I usually do is to complete the procedure, don't waste any more time measuring. And finally, in the post-op or even the next day, we take all the measurements with the programmer and do exactly as Vidal is saying to try to establish which of the leads has the latest ECG, and according to that to program the device. Honestly, I do believe, and there is some evidence in the literature, that not necessarily a broad QRS, a wide QRS, It's not an indicator of response, but definitely we know that when we have a narrow QRS after implanting the device and there is an improvement of the QRS, definitely there is higher probability of response in the long term. Now, this is a quarter lead. This is a quadripolar lead. Vidal, I would like to ask you, how many of you would program multi-point pacing at this point? And how many of you will not activate the multi-point pacing? Well, how many of you would program to start with conventional or multi-point? The conventional ones, raise your hand, please. Those who go direct to multi-point, raise your hands. I would say that one multi-point per 3 conventional. Personally, I believe. What do you think? Conventional to see the response and leave the multi-point for later. Well, according to the clinical response you see on the patient, yes, perfect. I have a variable perception. I think that if it's a patient who definitely has a very severe and advanced cardiac failure with multiple decompensations, honestly, I prefer somehow to activate multi-point pacing from the implant. But if it's a patient that you are going to treat because of incomplete block with moderate decrease of the ventricular function, I would agree in that case to do bipolar stimulation only and follow the patient. Another point is that in every patient, I am interested to see the effect. Maybe I am interested about the effect of the QRS when stimulating multi-point the first day. And if you see that it's much better, that can determine your decision. We have a question from the audience. No, I'm sorry. My name is Carlos Guzman from Mexico. I think that we are discussing whether the QRS is wide and multi-point, but we have not assessed the resynchronization. You assess that you are in a good site with a very favorable distance for resynchronization, the distance from the right ventricle, but we have not seen the effect of both electrodes or leads at the same time. Maybe it's worthwhile to try them. If you chose the dipole 2 to 3 or 3 to 2, I think it would be good to try the coil. But you cannot say that you are going to turn on the multi-point because we don't even know the answer to resynchronization. I think that you can optimize that later on when you know the values with the ECG. Yes, I agree with you, Carlos. Now I am just with the leads. I am going to remove the sheath while we are closing, we can look at the response with the programmer. As I said before, we usually do it while we finish the implant and then in the post-op and on the next day. And when I talk about activating multi-point pacing, probably we will do it afterwards. It's not at this point that we will do it. But I think that your comments are very valid. Is the other room ready? Well, thank you, Diego. You have very good thresholds. You have the ideal position, and thank you very much. So let's go to the next room. Yeah, perfect. Good afternoon to you all. Well, what we have done here is, this is the first complete image. The first image, please. In the apical area, we had R waves of just 1 millivolt. This patient has a severe cardiomyopathy. We raised the outflow tract, and here we have the wave of 12, 14. So the electrode of the right ventricle is somewhat up. It's not in the apex. This was only, well, this is the access to the coronary sinus with an external Medtronic sheath. We did a venogram, and apparently there aren't many options to access. So we decided to do a venogram with balloon, which is the next one, inflating the balloon in the cardiac vein. We see the anteroventricular vein. We see the filling of the vein, but we don't see much. On the next one, we see that there is a small vein here present. So we do a venogram further down. But what's important of a balloon angiography, in my opinion, is to wait for this moment. When you continue to inject as the balloon deflates in order to acknowledge the proximal veins. Here we see a small vein. We don't know how good it is, but we are going to proceed to introduce in the coronary sinus in order to have more access. We are going to introduce an external cannula, and through that external cannula, we are going to cannulate selectively the vein to see whether we have any luck. This is live. These are not recorded images. This is live. We don't see very clear the image. I am showing it live. I need some contrast. I am in RAO. In the other room, we were able to see better the LRO. I need more contrast. Could we move the image because they can't see anything with this image? No, this is worse here. And how about here? No, it's worse. Let's take an AP. No, it's worse. LIO. I don't know why it's so dark. Why don't you amplify? Because I don't see anything now. You can put the filter here. Maybe we can see it better with the filter. The thing is that the lung is covering the rest of the structures. You can leave it here. How about it? You can see it better now? No, well, we don't know where we are yet. We are placing a guide